Hello everyone. So in this video, we are going to discuss about the rheumatological disorders in the childhood. Uh, so uh, the most commonly asked questions from this area is about the Kawasaki disease and four clinical findings in the Henoch, Knoll, and Purpura, diagnosis of the systemic onset juvenile rheumatoid arthritis. Then another question is regarding classified juvenile idiopathic arthritis. And the next question is joint involvement in the juvenile rheumatoid arthritis, clinical characteristics of that. And also, that is most common area is juvenile idiopathic arthritis. Then we have Kawasaki disease and the Henoch-Knoll and Papura. These are the most commonly asked short notes or the short essays regarding the rheumatological disorders in the pediatrics. So first we have to start with the juvenile idiopathic arthritis. So in that we have to discuss the pathophysiology, clinical features, and management of the juvenile idiopathic arthritis. So first of all, we have to begin with the definition. Juvenile idiopathic arthritis is a group of disease with arthritis of unknown cause. That is other disease which have to be excluded and has been characterized by usually the age of onset is less than 60 years and the duration greater than or equal to 6 weeks. So these are the definition for the juvenile idiopathic arthritis. That is a group of disease with arthritis of the unknown cause. So we have to exclude the other diseases, and that is characterized by the age of onset is less than 16 years of age and the duration of greater than or equal to 6 weeks. That is the definition for the juvenile idiopathic arthritis. And about the prevalence, it is about 1 in 1,000 children. The prevalence of juvenile idiopathic arthritis will be there. Then about the etiopathogenesis, if there is a genetic predisposition along with the inflammatory mechanism that is responsible for the etiopathogenesis of the uh, juvenile idiopathic arthritis. Then about the clinical features of the juvenile idiopathic arthritis, we have first clinical feature is the morning stiffness greater than equal to 1 hour duration, the swelling of 3 or more joints, then swelling of hand joints like proximal interphalangeal joints and metacarpo-interphalangeal joints and the wrist joints. Then we have the symmetrical swelling of the soft tissue swelling will be the and the subcutaneous nodules, and we have rheumatoid arthritis factor in the serum and also erosions in the hand or joints on X-ray. So these are the clinical features of the juvenile idiopathic arthritis. That is it is remembered by the M as for uh, re. That is M as for re. That is M is the morning stiffness was greater than or equal to 1 hour. Then 4 S's are there. That is swelling of the 3 or more joints, the swelling of the hand joints, symmetrical swelling, and the subcutaneous nodules. And the RE is indicative of rheumatoid arthritis factor in the serum, and the erosions is erosions in the hand or joints on X-ray. So MS for re. So these all clinical features should be therefore greater than or equal to 6 weeks observed by the physician. So that is the characteristic feature of the juvenile idiopathic arthritis. So to diagnose the juvenile idiopathic arthritis, the 4 out of the above 7 criteria should be satisfied. That is above criteria which include MS for a re. About 4 of the above criteria should be satisfied to confirm the diagnosis of juvenile idiopathic arthritis. Then what are the red flags for the juvenile idiopathic arthritis? That is the juvenile idiopathic arthritis is characterized by joint pains greater than 6 weeks duration. That is must. Then if there is any history of the skin rash or mouth ulcers or alopecia or nail abnormalities will be that is common association. Or the other like red flag sign is presence of fever that is usually absent except in the systemic juvenile idiopathic arthritis. Examinations showing joints which are warm, swollen but not erythematous. And then we have a pediatric gait, arms, legs, and spine is a simple 3-minute procedure to screen for the juvenile idiopathic arthritis and joint pains. So that is all regarding the clinical features of the juvenile idiopathic arthritis. Then about the classification, it is also asked as a sub question in the essay question. So the classification of juvenile idiopathic arthritis include oligoarticular, Then polyarticular and systemic. Oligoarticular contribute to 50 to 60% of the juvenile idiopathic arthritis. And in that, less than or equal to 4 joints in first 6 months. Later, more joints are involved. That is extended oligoarthritis. Then we have polyarticular. That is in the polyarticular. If the rheumatoid factor is negative, 30% cases. But if the rheumatic factor is positive in the 10% of cases. In these cases, the greater than or equal to 5 joints in first 6 months is involved. In this case, also greater than 5 joints and the rheumatoid factor is positive and twice 3 months apart. Then another classification is systemic juvenile idiopathic arthritis. Here the features are fever for greater than or equal to 2 weeks along with arthritis is there. Then one or more joints are affected plus rash is present. That is the systemic manifestation of the juvenile idiopathic arthritis. And there will be along with that there will be generalized lymphadenopathy, hepatosplenomegaly and serositis will be there. So these are the classification of the juvenile idiopathic arthritis, that is oligoarticular, polyarticular, and systemic juvenile idiopathic arthritis. Then how will you diagnose the case of the juvenile idiopathic arthritis? We have to investigate by diagnosis is usually by the clinical and diagnosis of exclusion. That is, we have to exclude all the other diagnoses for the arthritis. Then we have to look for the CPC, anemia and chronic inflammation, that is CRP and ESR is raised. And also we have to look for increased lymphocytosis in the systemic juvenile idiopathic arthritis, because the generalized lymphadenopathy is a characteristics of the systemic juvenile idiopathic arthritis. Then we have to look for the rheumatoid factor. If polyarticular, it is not diagnostic. To prognosticate and classify, we have to look for the rheumatoid factor. And also, the anti-nuclear antibody is positive, increased risk of developing asymptomatic uveitis, and USG local and X-ray local part is also taken. These are the investigation for the rheumatoid idiopathic arthritis. Then differential diagnosis are if there is oligoarticular, the classification is oligoarticular, polyarticular, and systemic. The differential diagnosis for the oligoarticular is reactive arthritis, tuberculosis, and inflammatory bowel disease. And for the polyarticular, there will be differential diagnosis like rheumatic fever, then vasculitis will be there. And for the systemic, there will be Kawasaki disease, SLE, and vasculitis. Then treatment is for the oligoarticular, we have to administer NSAIDs for the 4 to 6 weeks, then steroids if necessary. In the polyarticular, we have to administer NSAIDs plus DMARDs, that is disease modifying agents, that is usually methotrexate plus steroids. And that is followed by the NSAIDs only, omit steroids, later as methotrexate takes effect. If there is any systemic, it has to be treated with the steroids and systemic steroids. The 4 groups of drugs are used. That is NSAIDs like naproxen, ibuproxen is used. Steroids like oral prednisolone, intraarticular triamcinolone, and IV methylprednisolone are used. Then another is the disease-modifying anti-rheumatic drugs like methotrexate and leflunomide. Then the biological reaction modifiers like infliximab and tocilizumab is also used. So those are 4 groups of drugs like NSAIDs, steroids. Then we have the disease-modifying anti-rheumatic drugs and the biological reaction modifiers. Then what are the complications of the juvenile idiopathic arthritis? Complication is, it is an immunological mediated disease. So there will be uveitis, that is painless blind eye. It is most prone in the case of oligoarticular juvenile idiopathic arthritis, followed by the polyarticular, and then followed by the systemic. That is more common in the systemic juvenile idiopathic arthritis. And if there is ANA, that is anti-nuclear antibody is positive in the case of the patient with the juvenile idiopathic arthritis, there will be increased chance of the development of uveitis. And therefore, 3-month eye checkup is recommended in the case of the rheumatoid juvenile idiopathic arthritis. And there will be growth issues, will be the deformities will be the because of the joint affections. And there will be, in the case of the systemic juvenile idiopathic arthritis, there will be macrophage activation syndrome, that is a life-threatening condition. And there will be also side effects of the drugs is there in this case of the juvenile idiopathic arthritis. Then about the prognosis, now disease-modifying anti-rheumatic drugs given early in the course as compared to NSAIDs is a new trend. A combination of DMRs is used. Oligoarticular and RA-negative polyarticular GA has best outcome, and the systemic juvenile idiopathic arthritis and the rheumatoid factor positive GA is unpredictable course. So that is all about the juvenile idiopathic arthritis. We'll discussed about the definition. Etiopathogenesis, that is genetic predisposition plus along with inflammatory mechanism contribute to the pathogenesis of the juvenile idiopathic arthritis. Then clinical features, that is MS4RE, that is MS4E. This above the criteria, 4 are satisfied for the diagnosis of JIA, then red flags for the JIA, then classification, that is oligoarticular, polyarticular, and systemic. In the systemic, we have generalized lymphadenopathy, fever, hepatosplenomegaly, and serositis. Then investigation, rheumatoid factor, INA positive, USG local, increased lymphocytosis in systemic JAA. Then also treatment. These are the 4 groups of drugs like NSAIDs, steroids, DMARs, and biological reaction modifiers. Complication also, uveitis is the most common, then growth issues, deformities. Then side effects of the drugs will be there. Then next topic is regarding the Kawasaki disease and other vasculitides. The Kawasaki disease also asked as a short note, or short essays in usually our university exam. So this is the classification of the vasculitis in the children. That is, there will be large vessel vasculitis, medium vessel vasculitis, and small vessel vasculitis will be there. Large vessel vasculitis example is Takayusu arteritis, and the medium vessel vasculitis example is Kawasaki disease and polyarteritis nodosa. And in the small vessel vasculitis, the diseases are the henoch-Schönlein purpura and the Wagner's granulomatosis. So these are the classification of vasculitis. Then the Kawasaki disease in detail, that is, it is the most common acquired heart disease. Kawasaki disease, it is a heart disease. That is, Kawasaki disease. It is the most common acquired heart disease in the kids in developed countries. Increasing incidence is being reported in India also. So it is the most common acquired heart disease in the kids. So Kawasaki disease is a small vessel Kawasaki disease is a medium vessel vasculitis. And it is most common acquired heart disease in the kids in developed countries. Etiology is obscure, that is genetic susceptibility along with immunological dysfunction leading to necrotizing vasculitis with a striking predilection for the coronary arteries. That is the etiology behind. There is genetic susceptibility along with immunological dysfunction that results in necrotizing vasculitis with a striking predilection for the coronary arteries. That is the etiology of the Kawasaki disease. Clinical features, age is less than 5 years, and if the boys are affected more than girls, usually the clinical features manifest at the age less than 5 years, and the boys are affected more than girls. Then about the diagnostic criteria, there are 6 diagnosed, that is, there are these are the diagnostic criteria for the Kawasaki disease. First is the fever lasting for greater than or equal to 5 days. Then illness is not explained by any other non-cause. And at least 4 of these criteria should be present. That is, among these 5 criteria, at least 4 of these criteria should be satisfied. That is bilateral non-purulent conjunctivitis, strawberry red tongue plus dry fissured lips. Extremities, they have edema and erythema, later disc formation of skin in palms and soles. Then have polymorphous non-vesicular rash will be the, then cervical lymphadenopathy greater than 1.5 centimeter, usually unilateral. These are the 5 criteria. Among that, for at least 4 of these criteria should be satisfied. And patients who do not fulfill the essential criteria are called the incomplete Kawasaki disease. More in the young infants, more chance of the coronary artery disease later. And cardiac involvement, which includes pancarditis, coronary artery aneurysm in the acute and subacute phases, and also thrombosis. And differential diagnosis of this Kawasaki disease are the measles, which is Sjogren syndrome, staphylococcal scarlet skin syndrome, scarlet fever, and drug reaction. So these are the Major, these are the criteria for the diagnosis of Kawasaki disease, that is bilateral non-polar conjunctivitis, strawberry red tongue or dry fissured lips, extremities like edema, erythema, later disformation of skin in palms and soles, then polymorphous non-vesicular rash, cervical lymphadenopathy greater than 1.5 centimeter, usually unilateral. So among these, 4 of these criteria should be present. If there is no essential 4 criteria fulfilled, it is called as incomplete Kawasaki disease. Because it is a acquired cardiac disease, the cardiac involvement include pancreatitis, coronary artery aneurysm, and thrombosis. Then about the investigation of Kawasaki disease, we have to go for the complete blood count. There will be increased WBC in the first week, thrombocytosis in the second week, CRP and ESR is increased, and and also we go for the urine proteinuria, and therefore there will be presence of proteinuria and sterile pyuria, and then ASO is negative, and 2D echo shows the coronary diameter of greater than 3 millimeters is abnormal, and there will be presence of carditis will be there. So these are the investigation for the Kawasaki disease. Then about the treatment, rest is important as a treatment method. Then IV immunoglobulins should be administered. That is 2 gram per kilogram over 12 hours, which may be repeated if resistant to second dose. And after that, we have to give the methyl prednisolone IV 30 milligram per kilogram per day for 3 days. That decreases signs and symptoms, but not coronary artery disease. Then we have to supplement the aspirin within 10 days of onset of disease, 80 to 100 milligram per kilogram per day, 4 days in acute phase, and 3 to 5 milligram per kilogram a day when ESR is normal for 8 weeks, if echo is normal. If not, continue till full regression of coronary artery abnormality, rarely lifelong. So treatment modalities are the rest, IV immunoglobulins, and the aspirin. The prognosis, usually the Kawasaki disease is a self-limiting condition. If it is untreated, 25% develop serious coronary artery disease. Giant aneurysm have the worst prognosis, and 0.3 to 2% have the mortality if treated on time, monitored for the hypertension, hyperlipidemia in the future. So these are all regarding the Kawasaki disease. ഇതിൽ ഓർക്കാനുള്ളത് എന്താണെന്ന് വെച്ചാൽ etiology, genetic susceptibility for immunological dysfunction leading to necrotizing vasculitis with a striking predilection for the coronary arteries, and it is the medium basal vasculitis, and these are the criteria. That is bilateral non-prolonged conjunctivitis, strawberry red trunk or plus dry fissured lips, extremities, edema, erythema, later disformation of skin in palms and soles, polymorphous non-vascular rash, cervical lymphadenopathy. So that is all regarding the Kawasaki disease. Then about the henoch-Nolan purpura, that is a small vessel vasculitis of childhood, which is characterized by the IgA deposition in the small vessel in the skin, joints, GIT, and the kidneys. The pathophysiology behind the henoch-Nolan purpura is it is deposition of the immunoglobulin A on the small vessel capillaries and venules with accompanying inflammation. So it is the deposition of the IgA along with the accompanying inflammation contribute that pathophysiology of the henoch-Nolan purpura, often preceded by the upper respiratory infections. So infectious triggers like beta hemolytic streptococci, staphylococcus aureus, mycoplasma, and adenovirus have been suspected. A disease mediated by the IgA and IgA immune complexes. That is the henoch-Nolan purpura. That is the disease is mediated by the IgA and IgA immune complexes. So this is a picture showing the rash in the henoch-Nolan purpura. Then what are the clinical features? We have in the skin, we have hallmark of the henoch-Nolan purpura is rash that is palpable. Purpura starts as pink macules or wheals and develops into petechia or ecchymosis. That is, first it starts as pink macules or wheals, then it develops into petechia or the ecchymosis. That is the hallmark rash in the case of henoch-Nolan purpura in the skin. And the lesions which are usually symmetric and found on the pressure points like buttocks area. Then that is buttocks and gravity dependent areas like lower limbs. Accompanying edema of the dorsum of the hand and feet which may be present. And other systemic manifestations of the henoch-Nolan purpura is that in the musculoskeletal system, there will be arthritis, arthralgia, and non-deforming. And in the gastrointestinal system, there will be abdominal pain, vomiting, diarrhea, paralytic ileus, and melena, intussusception, and mesenteric ischemia, which may also occur. And in the renal system, there will be nephritic syndrome, nephrotic syndrome, acute or chronic renal failure. Then CNS, we have the intracerebral hemorrhage, seizure, headache, and behavioral changes. And the diagnosis is mainly clinically by the specific rash. Then leukocytosis, thrombocytosis, mild anemia, and elevated ESR and CRP will be there because of the associated inflammation. Occult blood in stools will be present. Renal involvement quantified by the urine analysis, blood pressure, serum protein and serum creatinine level assessment. Then renal biopsy when required shows endoproliferative glomerulonephritis and ultrasound abdomen for the renal and GI complications. Then how will you treat the henoch-stolon purpura? It is by the mild and self-limited henoch-stolon purpura. We have to give only the supportive treatment, that is as nutrition, hydration, and analgesia. Analgesia, we have to give the naproxen, and this for steroids for the significant life-threatening manifestation. That is, we have to give the steroids for the significant life-threatening manifestation of the henoch-stolon purpura. Prednisolone 1 milligram per kilogram per day for the 1 to 2 weeks, followed by the tapering of the dose of the prednisolone, reduces joint and abdominal pain, but uh, does not lessen the renal involvement or the alter the cause of disease. If there is any chronic renal henoch-stolon purpura along with the steroid, which may need immunosuppressants like cyclophosphamide, cyclosporin, azathioprine, etc. So that is all regarding the treatment. That is supportive treatment for the mild and self-limited HSP. Then analgesia, that is as nutrition and hydration analgesia. For analgesia, we have to give naproxen. For the significant life-threatening manifestation, we have to give the steroids like prednisolone. So in the chronic renal HSP, we have to give, along with the steroid, we have to give the immunosuppressants. So that is then prognosis, overall prognosis is excellent for the henoch-stolon purpura, acute and self-limited course lasting up to 4 weeks. And the recurrence is common, but milder form is there. Long-term prognosis depends upon extent of renal and GI involvement. So that is all regarding the henoch-stolon purpura. And that is all regarding the rheumatological disorders in the pediatrics. Thank you.